So good morning, everyone, and welcome to the last installment of our Nursing Health Services Research and Policy Tuesday morning colloquia for this semester. Today, we are very grateful to have Ben Reynolds, who's the Chief Advanced Practice Officer for UPMC, where he oversees strategy, scope of practice, and policy for 3,500 physician assistants, nurse practitioners, nurse anesthetists, and nurse midwives throughout the UPMC health system. Additionally, Ben serves as co-director of the University of Pittsburgh Health Policy Institute's Center for Interprofessional Practice and Education, where he and his team design, execute, and study new models of team-based healthcare delivery. And I know they're collaborating with some School of Nursing faculty on some innovative models. Ben is a clinical assistant professor of surgery for the University of Pittsburgh School of Medicine and an instructor for the University of Pittsburgh Physician Assistant Program. He practices in the Division of Trauma and Acute Care Surgery at UPMC Presby, and he served in the United States Navy as a corpsman during the first Gulf War. So Ben, thank you for your service, and happy Thanksgiving to everyone. Without further ado, go ahead and take it off, and everyone feel free to ask questions throughout, and Ben would like to make this as conversational as possible.
Well, thank you very much, Haley, and I hope all of you are well. I hope your families are well, and I hope you enjoy this talk. I was when I was asked to give this this discussion, you know, I hadn't been really thinking hard about some of the policy matters that face my workforce, advanced practice providers. But I was heavily involved with a lot of work that we have done around team-based care and around value-based care within the UPMC organization. And one thing that has become quite clear during this this pandemic is the highlighting of why healthcare volume continues to matter within the national within our national healthcare system. As I was titling this, obviously it was around Halloween, and I have a 14-year-old and an 11-year-old, and we're talking about different different Halloween sort of items, and it just occurred to me that this might be more of a discussion that we should frame as in terms of zombies, because healthcare volume really hasn't gone away. And so this is a talk a little bit about the health economics of zombies, and I'll explain that as we sort of go along here. I have no disclosures. My hope is that by the end of this talk, you'll have a good sense of the healthcare payer environment, because that really underpins a lot of what we're going to talk about during this this talk. You're going to get a good, I hopefully will spark a good discussion about the persistence of volume over value, and then as it relates to my workforce, because one of my areas of interest is around providing not just value-based care, but the use and the utilization of advanced practice provider workforces into professional team-based care as a matter of delivering that that value. And so we're going to talk a little bit about some of the struggles that we have nationally and specifically within my organization about attributing value to advanced practice providers. You guys know how big we are. We're the largest non-governmental employer in the state. We have a lot of advanced practice providers. In fact, I believe that we are the largest non-governmental employer of APPs in the nation. But more importantly, I want to sort of draw your attention here to the number of patients that we have covered under the UPMC health plan. We have a pretty good large market share, which drives a lot of our strategic thinking around both volume and value-based care. And it's a bit of a push me, pull you. UPMC is different from other healthcare systems in that we are what we call a vertically integrated health delivery and finance system. And by that, what we mean is that we, at the very sort of top of our economic model, is our health plan, and the health plan controls the dollars that go to the other arms of our delivery system, which are our providers, our physicians, our advanced practice providers, and then the services that we provide including our hospital inpatient admissions, as well as radiology services, among others. And so the health plan gets their money from patients who are paying premiums to them. They then pay us for the care that we're providing. And ideally, in an optimal working situation, we are able to provide care that has a cost that is less than the premium that has been paid by the patients who are covered by our health plans. And when that happens, then we're able to save that money. We're able to put that money back into helping to keep the cost of care down and keep the profitability of our enterprise going. One of the sad realities in healthcare in the United States is that it is a capitalist-based system. We are not a socialist. We do not have a strong social network of healthcare system like they have in Great Britain and in Europe. And so the health and sustainability of our healthcare models is really predicated on being able to make money and sustain some margin of profit by the end of the day. So when we're not able to do that, and the cost of care is then starting to exceed how much is being paid in premium, then we start to see that money. Lose away from the organization, which then hurts us in the bottom line and all of the missions that we provide. So, but that's not really what you hear, right? What you hear in the popular media is that in healthcare we are making money hand over fist. Hospitals made $21 billion on Wall Street last year, but are the patients really seeing those profits? And this was an interesting story that I happened to be listening to driving on a trip last year about how nonprofit health hospitals are driving up the cost of care. And when you look at these stories and it's sort of this sort of one-sided view, sort of the impression that you're left with is that that we're really hurting patients, and that we're profiteering off of the sick. These statements that hospitals are the largest individual contributor to healthcare costs in the United States, there's obviously a nugget of truth to that, because in order to deliver healthcare, hospitals have to function. But it gives the wrong impression about what's going on in the greater health economic. That somehow we are just making money hand over fist, and that and that's what it's all about. But that is simply not the case. It's not easy to make money in healthcare. And what you see here is sort of a stratification of the different areas of the health sector and how much they're making in health profits. And what you can see here, this was provided by CMS, is that drug manufacturers are really killing it out there. Big pharma makes a great deal of profit over places like hospitals or health plans. Across the country in 2019, we saw healthcare systems make an average of $20 billion in profits. And this was on $3.5 trillion in healthcare spending, both by the patients as well as by the healthcare systems to provide that care as well. And when you looked at how much money each one of those healthcare systems were making, the total profit margin was only 0.5, 0.6, we'll round it up, total profit margin. Now, to give you some perspective, let's look at what happens in my own organization. We're a nonprofit organization. We publicly report our financial data. This is all discoverable on the web. In 2018, we didn't see a great deal of movement in our volumes, and so it really contributed to a very slim operating margin. We, like other healthcare systems, saw about $20 billion in net revenue, the total amount of money that we saw in there. But the expenditures were so great that we really, at the end of the day, saw about $166 million in profit, which equated into a 0.9% operating margin, which puts us pretty high in terms of the amount of the fiscal health of like healthcare systems. And so compare this, though, against the profit margins that are made in the private sector. And you see here Walmart 2.1%, total market 7.9%, and folks believe that that these private industries are making about 36%. But compare that against some of the top profit margin businesses out there. Tobacco, 43% profit margin. Financial services, 26.4%. So if I were smart, I probably should have went to go work at a bank, because they make a lot more profit margin, or work work in the tobacco industry, because they make a lot of money on the relatively little amount that they spend on their industry. So the bottom line here that I hope I drive home is that in healthcare, you really need to spend a lot of money in order to make a little. And the fact of the matter has been is that along the way here, as healthcare policy has changed and we have been forced to adapt to that, we have learned the hard way that volume matters. And we're going to go through this pretty significantly. But in order to understand this background, it's important for us to discuss sort of where these sources of revenue come from. We give a lot of lip service about government payers, specifically CMS, but Medicare really isn't what pays the most. And this was a study done by Rand that looked at how much we are paid relative to private health plans. And among hospital systems, prices varied nearly threefold. There's no real standardization across hospitals in terms of prices, but what they saw was a ranging from 150% of Medicare reimbursement rates at the low end to up to 350 to 400+% at the high end. So this is really where hospitals and providers see the majority of their revenue coming from, is by payment from private health plans, and not so much from Medicare. But what we've done very well over time, and this is a direct effect of the Affordable Care Act, has been to drop the number of people who do not have insurance in this country, and it has just plummeted down from a high of 17.8 over the last 11 years. Now we're sort of hovering right about 10.9%. And in Pennsylvania, under Governor Wolf's leadership, accepting the Medicaid expansion, we have seen our non-elderly insurance uninsured rate drop down to 6.9%. And so we've done a very good job of that. But the fact of the matter is that for those patients that don't qualify for either Medicaid or don't have an employer-provided health plan, the fact of the matter is that there's still some major barriers out there to folks getting insurance coverage to pay for their health care. And this top one here has been a point, certainly for me, of an area of focus, but also something that's worth a good deal of discussion here. And let's talk a little bit about why this coverage is not affordable when we talk about the availability of health care insurance for all. What the Affordable Care Act really ultimately was sort of a compromise between the desires of the government to create greater amounts of coverage for patients that need it, and the continuation of the traditional capitalist, and I only say capitalist because I can't think of a better word of framing the sort of business model of the traditional, I guess might even be better, payer systems that are out there with these private insurers. And it all revolves around who is paying the proportion of healthcare costs. And so the way that we're able to keep healthcare costs under control under the Affordable Care Act is to distribute costs between the patient and the payer. And so what happens in cost sharing is that we take some proportion that was traditionally paid by the payer, and we share that between the patient and the payer. And what happens is that we then push some of that cost over to the patient, some proportion of that. And as we're distributing the cost of that healthcare, and that sharing increases, the stoichiometry of cost going back to the patient, we start to see monthly premiums start to decrease. But it really hasn't really been terribly helpful, because in cost sharing, it still puts a proportion of cost back to the patient, with decreasing their ability to pay for this. And this next graph from the Kaiser Family Foundation really helps to illustrate this. This is a graph looking at premiums and deductibles against workers' wages over the past 10 years. And what you'll see here, a special attention to the black line down here at the bottom. We've only seen a 15% increase in earnings, certainly between 2014 to 2019. But disproportionate or disconnected from that modest rise in earnings, we've seen a 28% increase in premiums, even with cost sharing in these consumer healthcare products. But what's been more striking has been the increase in deductibles, the amount of money that is out of pocket for healthcare costs paid for by the patient before their health plan or their health benefits start to kick in. And we've seen a 76% increase in those deductibles. Again, we're not seeing earnings increase, keeping pace with the amount of cost sharing that is going on as it relates to attribution in the deductible side. But what's really even more striking, so deductibles are rising 6 times as fast as wages, but it's really striking when you do this against the overall cost of what consumers are spending on healthcare, right, or utilizing in terms of healthcare. So down here in the dotted line, this is healthcare utilization. So this is a function of how often patients are using healthcare services. And really, it's only about 3.1%. But we're seeing spending, right, as a function of that, go up dramatically. 18.4% of that is incredibly high, with an increase of the price. And the price of that healthcare and the amount that we're spending continues to go up, even though the Affordable Care Act has been in place to help put a check on these costs. And this is really what sort of drives it home for me, and has really been powerful in shaping my own view about how to maximize our interprofessional team-based care to effect. It's that as a function of total spending per patient in 2018, professional services, which are services provided by physicians and by advanced practice providers, made up the greatest proportion of what was spent by an individual in their health, what individuals are spending on their health care in 2018. And this is where I see the greatest opportunities, certainly within my sphere, to help control. So, as I've sort of gone over here, when the Affordable Care was enacted, one of the mandates that it had in place was to both to expand coverage, but also to help control costs. And what you can see here is that when the Affordable Care Act was put in place, we did see a dramatic increase in expanding coverage. But if you look at the total national healthcare expenditures over time, we did not see any real control in spending. And so for most of us to keep healthcare affordable and to keep it from sort of going off the rails, one of the things that we have to be focused on is how to contain costs moving forward. So this really brings me to the larger discussion that has been going on around value in healthcare. And for those of you, obviously, if you're on this talk, you have a strong interest in healthcare policy. You're familiar with the work of Dr. Porter, an economist who at the time was at Harvard, wrote this amazing article that I still have a paper copy of to look at, and it was titled "The Strategy That Will Fix Healthcare." And what Porter's rationale was that we need to get away from sort of churning through patients, seeing patients, as many patients per unit time as a mechanism for reimbursement, because it puts in the wrong kind of incentives for healthcare systems. And I, in part, agree with that. And I've worked hard over the years, certainly within the last 10 years that I've been in my role at UPMC, to put in value-based healthcare mechanisms to help fix that. Because as we all know, the fact of the matter is that so much of the care that we provide isn't of the highest quality that it should be. It's not as safe as it could be. And as a consequence, as you've seen, the cost of healthcare continues to go up, but we've not seen a concomitant increase in the quality of that care that has been provided. And this overall strategy that Dr. Porter presented was supposed to make the days of business as usual be over with. But the fact of the matter is that just hasn't happened. And this is where we start to talk about the persistence of volume and how it's been very, very difficult to sort of kill that. And so zombies persist. And so you might be asking yourselves, why do we even talk about volume? If there has been such a focus on this and we've had such a legislative effort around shifting from volume to value, why do we even continue to talk about it? Well, the fact of the matter is that this is one of those policy topics that there has been a great deal of disconnect between what has been put out in theory, what has been enacted legislatively, and then what actually happens in the real world, in the healthcare delivery business. And healthcare systems have to continue fighting the Cold War because they're forced to. The market really requires us to be looking at the amount of patients that we have to take care of. We have baby boomers, 10,000 of whom are retiring every single day. And the baby boomers that we are seeing, this older generation, are sicker. They have more medical comorbidities. They require greater medical management. They require more time. And there's a lot of reasons why that's true. People are living longer. And that's resulted in significant wait times. And when patients have to wait for their care, not only is it a patient satisfaction issue, but there's a real morbidity and mortality associated with having to wait to get in to see your providers. And so the more people that are entering the healthcare into our clinics and into our hospitals that have to wait to see a patient, the sicker they actually end up becoming. And then there's this whole other element of millennials and sort of this need for instant gratification, that wait times simply don't matter, and so we're losing a lot of these millennials, these younger folks, to not being able to get good healthcare because it just takes too long, and there's an impatience factor that all healthcare systems have had to adapt to. And this is when we talk about the older folks in our patient population, we really are seeing a dramatic rise in the number of patients that are over the age of 85, which is where a lot of the healthcare spending occurs in these sicker, older individuals. And just to give you a perspective here, Pennsylvania is has the second highest number of patients over the age of 85 in the country. And so this really matters to a great deal for healthcare systems in Pennsylvania. And as I said before, we've done a really great job of insuring folks in the Commonwealth. But as folks have increased the number, as the number of people who have become covered has gotten either insurance through the Medicaid expansion or have gotten insured through the healthcare marketplace, that also means these are people that need access to healthcare, right? And that number continues to go up. And this brings me back to the numbers that I showed you at the beginning, talking about the growth of our own UPMC health plan. We now have 3.8 million folks who are covered by the UPMC health plan. As those folks have become members of our health plan, they too require access. So we're seeing a great deal of increase in volume from the Medicaid expansion, from expansion in the healthcare marketplace as well. So, but what has really driven home this focus on or the importance of volume has been within the last year. And as with every conversation I seem to be involved in, and not wrongfully so, as the number of patients have become sicker with COVID. COVID has really laid bare the need for volume and the dependence of volume healthcare systems have. There have been $120.5 billion in financial losses due in large part to lower patient volumes between July 2020 and December 2020, an average of $20.1 billion per month. Hospitals are simply taking a bath, and that has brought losses to the healthcare systems on average of about $323.1 billion during this year. So this has been a real problem for the nation because it threatens the health and the sustainability of healthcare systems. And I like to bring it
Ben,
home.
we have
Yes.
a question from
Good.
Stephanie. How do you see the clinical nurse specialist APP role influencing value-based care at UPMC and nationally?
That's a really, really great question. So, uh, clinical nurse specialists, as you know, are one of the five advanced practice provider roles that are recognized under CMS. And one of the problems that we see in the state of Pennsylvania has been sort of a lack of scope of practice protection for clinical nurse specialists to help to define what they do necessarily. And I think part of that has been related to Pennsylvania being, I think, sort of last to the table as it relates to the clinical nurse specialist role. And also, I have to tell you, because I've had these conversations with other people who do my job in other healthcare systems. Some have been able to find a very strong place for their clinical nurse specialists to thrive in healthcare delivery. Uh, Other places have not, and so they have not adopted the role nearly as in depth as others. So I think it's been a part of lack of experience with the role, and I also think that has been a lack of legislative activity to help create the right sort of scope of practice protections for clinical nurse specialists. Does that make sense?
Yes,
That makes sense to
that's
me.
been my experience.
Yeah. In West Virginia, I think is a good example of that. They're a full practice authority state for nurse practitioners, and they've also really embraced the role of the clinical nurse specialist, and so they have integrated that role, quite well. Interestingly enough, in West Virginia, contrast that with Pennsylvania. We are not a full practice authority state for nurse practitioners or for APRNs, and we also don't have title protection for the clinical nurse specialist role. Right? It's a tale of two states.
I thought we got title protection. Didn't we get title protection?
If that's true, then we've not done a very good job of adopting it at hospitals
We
and
did
healthcare
get
systems.
title protection, I think in 2008. But the scope has not been expanded. You're right. Yeah. My experience, even in Pennsylvania, has been it's very different on each side of the state. And on the East Coast, the role I practiced out on the East Coast, and the role is widely used, and then not so much on our side of the state now, but which is kind of interesting because the state government runs both sides of the state.
Right,
So
right, right.
so
But
it's
but but I think it's a matter of familiarity. I mean, I really do.
yeah,
Some places use the role, as I said, to effect. Right.
yeah,
They have their clinical nurse specialists in very high functioning roles. Again, it's just not something that Pennsylvania has been a leader on,
yeah.
and I think to their detriment. When you talk about interprofessional team-based care, it's about using everybody who is on the team to their maximum potential, and I mean that's simply a failing of the state. I would argue.
I would agree.
Yeah, not that you're biased or anything, are you, Stephanie?
Yeah. Anyway,
Right,
thank you.
no problem. So we're losing money, and things look bad. And let's talk a little bit about UPMC because there was we received a lot of criticism for maintaining elective operations and surgeries for as long as we did. But the reason that there is this sort of tension between what the government wants us to do in a pandemic and what we need to do to be a sustainable entity is sometimes in conflict. Because if we're not doing elective operations, then that results in lower revenue streams, which can then threaten the health of the system. And when you look at the larger macroeconomic around that, when as a function of UPMC being as large an employer within the state, that could threaten jobs, and that's something that is really in the front of all of our minds. Certainly, those of us in leadership, as we have this discussion, how do you balance delivering the right kind of care during a national healthcare crisis, while at the same time not handicapping yourself so much that when the crisis has passed, that you can't continue to be an economic engine of employment and sustainability for the state, as well as continue to carry on your mission. It's a very, very difficult balance to strike. But let's talk a little bit more about what we saw nationally happening in other segments of the state. NPR, amid the pandemic, hospitals laying off 1.4 million workers, healthcare workers in April because of that volume went away. Within the advanced practice provider workforces, there was a lot of notoriety that was given to the American Academy of Physician Assistants. They gave an interview in the Wall Street Journal. It was picked up by a number of different news outlets, and I have to tell you, it was forwarded to me no fewer than 100 times about the crisis for physician assistants during the coronavirus outbreak. More than 1 in 5 PAs, or 22%, had been furloughed due to COVID-19, while nearly 4% said they had been terminated. 59% said their work hours had been cut, and 31% said their base pay had been reduced. And speaking on behalf of UPMC, I'm proud to say we did not furlough advanced practice providers. We actually maintained a pay guarantee, and a lot of our losses were offset by CARES Act money. Many healthcare systems took CARES Act money as a mechanism to help sort of maintain revenue streams during this time. I don't have data on APRN roles, but I've talked with other healthcare systems. They had the same problems with all of their APRN groups. That they were furloughing them, they were idling them at home because volumes went down as dramatically as they did. And so this vulnerability has really translated into a negative impact on the business of healthcare over time. And Moody's, which is a bond rating agency and is really the top grader of the financial health for business, changed its outlook for for-profit hospitals to negative as a result of the coronavirus outbreak. So let's get to this question. Let's answer the question: did value-based reimbursement actually kill the volume zombie? To really answer that question, we have to talk a little bit about some of the systems that were put in place, the new CMS reimbursement systems that were supposed to help move us to volume to value. And the first one I want to talk about is MIPS. And this is where people will sometimes kind of get a little bit glassy-eyed when you talk about it. MIPS was put in place in 2015 after the Medicare Access and CHIP Reauthorization Act. It was a new world of value-based care to many physicians, and was a mechanism to try to wean providers off of the fee-for-service mechanism of reimbursement. So it doesn't simply reimburse seeing patients at a particular volume. It scores providers, including advanced practice providers, based on their quality and performance using a 100-point scoring system for the patients that they see in a particular calendar year. And so your reimbursement is strongly influenced by your MIPS score. And so for each year, MIPS sets a predetermined threshold to be the number of points at which providers earn a 0% adjustment to their payments. And for each point you earn above that threshold, the amount of adjustment to your reimbursement will increase. But if your points do not exceed this minimum threshold, then a penalty is associated, and so you lose money. And this is the percentage that was set for the MIPS program, and you could really kill it if you did this very, very well. So if you're an exceptional MIPS performer and you were able to see patients that are super high quality, you could have seen up to a 120% increase in your fee rate. But on average, this is what was predicted, that folks would sort of stay around this base here. In some of the advanced payment models here, you could see even more money. But if you're really saddled with these penalties, you could lose money. And so this was supposed to help providers wean off of that fee-for-service system. It costs a lot of money to implement the requirements of MIPS, including the use of technology and an integrated health EHR, electronic health record. And so a lot of people made the investments necessary to come into alignments with MIPS, But the sad part is that it really didn't pan out that well. And I was and I'd be interested in the conversation around this, because I haven't found a lot of good scholarly data around the success or failure of some of these advanced payment models, certainly MIPS and any of the other the macro programs that are out there. But in 2019, which is based on 2017 performance data, 71% of MIPS participants received a positive payment adjustment with a bonus for performance. And that's great, right? Because that means that the majority of people who participated won. 22% received a positive payment without the bonus, and 2% didn't receive a positive or negative adjustment, and only 5% received a negative adjustment. But when you put this against the amount of investment necessary to stay in compliance with MIPS reporting and the quality metrics behind it, it just really didn't pan out, because the maximum payment adjustment was only we can round that up to 2%. But if you didn't do as well, right, after making the major investment to come into alignment to do this, then what you got was a penalty. So the downside of this risk was greater than the upside for most people who were participating in the MIPS payment model.
Yeah. And so Ben, this is Grant. So
yeah.
A couple of papers that we wrote, they weren't specifically about MIPS, but they're about medical homes more generally, found that another big problem is that there is this scale that large practices have, that they can centralize some of these investments, particularly in IT, care management, care coordination. And so people that were getting killed by this were small 1 and 2 physician practices that were, trying to invest in these IT capabilities, and they were spending millions of dollars. I have this story of a physician that I interviewed that in the middle of, it wasn't the MIPS program, but it's something similar, where he just put up his hands and said, screw it, and went to the Indian Health Service and just quit practice altogether, just because he just couldn't. So I think this is a continual way that we sort of concentrate power in the hands of, for better or worse, places like UPMC at the expense of small practices.
And you're not wrong about that, Grant. I will tell you, and this has been true for us for years, that we don't necessarily seek out practices to merge into UPMC. They seek us out, and a lot of it is because of the cost of implementation. To your point, and healthcare systems like Susquehanna and Pinnacle, and Western Maryland most recently, we have that advantage in that we've established this sort of baked-in cost of infrastructure to be in alignment with these value-based programs, which is a cost that they don't have to incur. We simply centralize it. It's corporate. It's available to everybody. And so they can just focus on actually hitting the metrics, right? They don't have to focus on the cost of the infrastructure.
Yeah, exactly.
That's a very good point, Grant. But it's not just about making money, right? Let's be clear about this. I hope I've driven home the point that it is important that we do the things that make this a sustainable healthcare system into the future until there's some change. But remember, part of this is also meant to change quality. And there has been some work that has looked at this. This was a paper from last year, looking at the association between the degree of exposure to hospital value-based purchasing program and 30-day mortality. So what did these value-based programs do to save lives, right? To improve the quality of healthcare during this pay-for-performance program. So the authors here looked at all the hospitals in the MIPS program and looked at the outcomes, the ones that including annual hospital level 30-day risk adjusted mortality rates for acute myocardial infarction, heart failure, and pneumonia patients. And what they found is that there was no real association or meaningful change in 30-day mortality across the hospitals when they were exposed to penalty. So it's not only hurting us in terms of the ability to be a sustainable business, but it's also not really doing a whole heck of a lot to change these 30-day mortality rates that we're penalized for over time. So gets us back to the question: did value-based reimbursement kill the zombie? I mean, obviously the answer is no. But more importantly, it's not hitting all of the outcomes that I think was originally set out. And so volume still matters. And not only does it matter, but it matters a lot. And let's go through let's talk a little bit about this. Haley, how am I doing on time?
So we are at 9:42. Got about 18 minutes till we close.
Okay. Well, I'll get through this fairly quickly because this is really sort of how the sausage is made in terms of how we attribute productivity to advanced practice providers. It really is, as I described before, how many episodes of care we're providing per unit time, and there's a number of different ways that we can measure this: patients per hour, patients per day. But really, this one here, work RVUs, are the way that we do it the most. Work RVUs are really sort of a complicated metric, and really it's about reimbursing providers for their expenditure of money in taking care of patients. It's made up of really 3 different variables. 52% of that work RVU is related to the work. 44% is related to practice expense, and 4% is for malpractice. And it's determined by Congress every year. And for 2020, one work RVU was worth about $36. But it only works for the services that you get reimbursed for. And so there's a lot of things that we do in healthcare that isn't necessarily measurable and that a work RVU isn't attributed to. But it also creates the wrong kinds of incentives. And as I used the word before, churning, it really puts incentives in place for providers to see as many patients as possible, sort of not just focusing on value because we need to take care of large populations and that volume is out there, but to see as many of them as possible in order to make more money. And advanced practice providers have really sort of lagged behind in terms of how we use that tool, because that really is the language of productivity in healthcare, about how advanced practice providers are looked at. We generate RVUs just like physicians, but much of what we do in our roles don't provide are providing services that don't necessarily generate RVUs, and that may be in things like postoperative care or in educating patients, and those things are valuable. These services are incredibly valuable because if we're not doing it, then someone else has to do it. And so the question always becomes, how do we measure that? And there's there's been an entire business sector that has opened up, that has been in the space of RVU valuation and benchmarking for physicians, but has now got into the business of doing this for advanced practice provider. And newsflash, they don't do it very well, because we have a major issue around attribution, because so much of what we do, these productive activities, are attributed to the physician in the modern reporting system: admissions, procedures, care encounters. And so our electronic health records, while they're sophisticated in these value-based ways to come into alignment with the payment models that are out there, don't do a very good job for accounting for advanced practice providers. And there's a lot of contributing factors here. A lot of it is that payers simply haven't modernized how they view advanced practice providers. Contracts for physicians really can potentially create a competitive disincentive between advanced practice providers and the physicians if their bonus is predicated on high work RVUs. But most of it is culture and ignorance, and there are some enormous barriers that we encounter. And I'm going to go through this because I think it's important for you to understand. I call it the Death Star of reimbursement.
Ben, can I interrupt real fast?
Absolutely.
So, talk a little bit about the difference between primary care and specialty care. Because in primary care, it seems as though NPs and PAs are billing Medicare, not the same rates, but similar rates as physicians, especially depending on the practice structure. But it's like the inpatient in the specialty area where it seems to me we can't track any of this care that NPs and PAs are providing, especially inpatient, especially inpatient.
Yeah.
What's your sense?
So part of it is because of the laws. So let's start from the federal level.
Yeah.
The law requires that if you're a participant as a condition of participation in the CMS program, that the patient has to be admitted to the hospital under a physician. That hasn't changed yet, and there's been a lot of talk about how to change that. There's been a lot of resistance from physician groups in changing that, but that has really sort of continued to empower this lack of attribution. So it starts right there, and almost all insurance companies, almost all payers, fall in alignment with what CMS guidelines put out there. Right. CMS guidelines are codified under law, so we have to follow them. And so payers, sometimes come into alignment with that. And so when they enroll providers, they spend a lot of time focusing on the enrollment of physicians to the detriment of enrolling advanced practice providers.
Yeah.
Now that's changing. And a lot of what has driven that change for focusing enrollment of advanced practice providers has been the successes that nurse practitioners have had in moving full practice authority in many states, because they have codified in the Full Practice Authority Acts in Maine, in Maryland, in West Virginia, and other states where full practice authority has come, that it requires the payers to enroll the APRN as a provider. And so when that happens, right, then that's where attribution occurs. Because if insurance companies are good at anything, it's understanding where they're spending their money, and they can then drill down that attribution. They will drill down that attribution to the enrolled payer. To the enrolled provider.
Yeah, sort of interesting. We're sort of rehashing all these problems of RNs where they become a budget item in the hospital budget as opposed to sort of revenue production. And so we're sort of rehashing that with APPs again. So this whole conversation we had about RNs and trying to make their work more apparent, we're just sort of having the same conversation 15 years later.
Yep.
Yeah.
Let me just jump ahead here, because otherwise I'm going to run out of time, and I really do want to talk about this. But autonomy matters. When you look at survey after survey, every single advanced practice provider, whether you're a nurse practitioner, a CRNA, or a physician assistant, you want to have some autonomy. And this competes against a lot of the work that we do around trying to create teamness, because autonomy is really a check on the cost of care. And I'm going to go through this, and this is really the most important part of this discussion here, because you can when you plot autonomy against team, you can understand how that happens. So in this first block here, when we have low teamness and low autonomy, it's very chaotic. Poor coordination. You have lack of leadership to help manage the team, and it's really associated with poor job satisfaction across all of the members of the team. So this is a box that we want to avoid. But if we ignore autonomy against teamness, right? So we have high teamness but low autonomy. Well, then we have a lot of costs for many episodes of care, because you're paying a lot of people to do very similar tasks. And so that can be quite inefficient, especially if the roles don't have good definition. And what happens also many times is that when you have highly team-dependent, team-centric care, if the team isn't complete, right? Someone gets cut as a result of budget. Right. Well, then there's someone missing from the team. It's like missing Ben Roethlisberger from the offensive line. Things don't function like they should. But if you have high autonomy but low teamness, this is the traditional model where the physician was the captain of the ship, and everybody else sort of played a secondary role. It creates fragmented care, and that's where we have been for a long, long time. It's also very inefficient, but as autonomy increases, we know that it can be professionally satisfying, but it incentivizes sort of the wrong behavior. It incentivizes very self-interested, and we want to get to this very sweet spot where we have high teamness and high autonomy, because when we accomplish this, care is coordinated, it's efficient, it's professionally satisfying, because everybody is practicing to the top of their license, to their fullest potentials. And when you have a fully functioning team, then it creates the right sort of checks and balances to make that care safe. We're all looking at one another. We're all talking about the care of the patient, all while doing our jobs to the best of our ability. So I'm not going to go through all of the, so this is really, this is work that I did with the advisory board some years ago about creating the ideal team-based staffing model of what we call parallel versus intersecting models, where we have advanced practice providers seeing their own patients and then physicians seeing their own patients, moving away from this high teamness model where every single patient is seen by every single provider, which increases the cost of care. This is a really nuts and bolts sort of discussion about why this matters in terms of cost, intersecting care models where you have a physician and an APP in a in a general surgical practice, right, can cost a lot of money, where if we have a parallel model, we keep that cost down and are able to really realize savings when we use when we balance that autonomy and teamness. When we have every single patient annualize these costs over a year, almost $1.3 million. But if we create a parallel model, then we can really reduce that cost of care. So let me just sum this up. my hope is that my case supports these conclusions, is that volume is really still a healthcare system's primary revenue stream. It's how we butter our bread every single day. Focusing on volume is absolutely necessary from an economic perspective in order for us to continue to sustain our healthcare system, but it's also important from a population health perspective as we increase the amount of coverage for patients that otherwise wouldn't have health insurance. Value-based strategies up to this point have not really put out a lot of evidence that show an impact on improving or sustaining, even just sustaining revenue or improving quality. And if volume is going to be the measure of patient access success, then healthcare systems, my own included, has to do a better job of improving attribution. So thank you very much for the privilege of speaking to you today. I'm sorry I went over time. I hope that this was informative for you, and I'm happy to take any questions.
Yeah. Thanks, Ben. This is Grant. This is really great. This is right on target. This is exactly what we were hoping for. So this is great. Real quick question, let other people chime in. That autonomy teamwork matrix, was that yours, or did you? I have a student doing her dissertation on these topics, and this might actually be an interesting framework for her to use.
So this struck me in a moment of I don't know whether. So we were talking about this. This was actually a conversation I had about 3 or 4 months ago with my staff, and actually I had just met with our CFO. And one of the things that we try to do is create mechanisms by which the advanced practice providers are at least through their productivity offsetting their overall cost of the healthcare system, right? To be, at the most break even, if not necessarily profitable. And I'm trying to I'm trying to sort of go through the things that have stood in the way. We want more autonomy, but we want more teamness. And those two things can actually compete against one another. It's
right.
You can't just say we want fully autonomous care, because then you have, box number 3 here. But if we have full teamness, and we know this because we've studied this, we've looked at it, we've put together high functioning teams that are, all about communication and taking care of patients. But that's a high cost model. I mean, that's a cost, because we have a lot of salaries in that team, and the bucket of money that we get back has to offset the cost of that team. So as an economically sustainable model, it kind of competes. Mm-hmm. But achieving autonomy and full teamness matters. So
thanks.
Any other questions that I can answer?
Ben, I have a quick question.
Yes.
First off, would you be willing to share these slides? Because I'm really interested in the numbers and things that you scrolled over with the surgery practices. I'd love to look over that.
Absolutely. That's all CMS reported data. That is not UPMC data. Absolutely. And I think I gave the slides. Haley, if you have them, there's nothing in here that's proprietary, that's not out in the either in the academic literature or in the public sphere.
Thank you.
All right,
and
Amy
then second,
Comagino might have a copy of them.
Oh,
yeah.
Yes, I do, and I'm happy to send them to you, Liz.
Thank you, Amy. And second, I was hoping that you could speak a little bit about, so in my own in my practice as an RN, I've seen like our NPs and PAs function almost simultaneously and in overlapping roles with residents, with certain, with trainees. And it seems to me that exactly like you talked about, we're having the same group of people doing the exact same job, and that's really inefficient care. I was wondering if you could speak a little bit about how we differentiate and make the most of both of those roles.
That's a really, really great question, Liz, and it's also a loaded question. So one of the things that I will tell you is that the implementation of the 80-hour workweek for residents has dramatically increased the number of employment opportunities for advanced practice providers across the country. That is why you see such an explosion in the groups. It came from this perspective that we had to manage work hours. But as we have, as volume has started to increase, and as expenditures have started to go up, and all of these different things that we talked about, this calculus that we have to balance, what we see sometimes is that there is a conflating of physicians that don't know what an advanced practice provider can do at fullest potential as being a learner no different than a resident, requiring oversight at the same way that a resident requires oversight. And we're not maximizing billing because in the GME world, billing with a resident is done much, much differently. CMS and payers look at advanced practice providers billing like a physician would bill, right? It's not the same. And so we have, for worse, I would argue, put advanced practice providers in a lot of these academic support roles to supplement resident staffing, either for work hours or manpower or whatever, but haven't really made the efficient use of them in the way that brings the greatest value back. This conflating of APPs with residents has been a real detriment to us. Ideally, what should be happening in the situation that you describe is that the advanced practice provider has their own patients that they're seeing. There are necessary intersections with the physicians for complexity of care, for coordination of care, or what have you. And then the physician spends time overseeing the work of the resident, right? And providing bedside teaching and all the things that we actually pay the attending physicians to do. But that's not what happens. What happens is that the workflow of the resident becomes the workflow of the APP. And so that's harmful to the cause.
Yeah, that's exactly what I've observed on our surgery teams, and it just when you spoke about it now, I was thinking I never thought about it in the efficiency terms. But I was like, yeah, that is a really inefficient use of our NPs and PAs.
That's the tip of the iceberg too, Liz. Yeah.
Yeah, I'm sure.
It really is.
All right, any other questions for Ben?
Yeah, this is Jennifer. I had one last question for you. We hear a lot in the media about insurers having profits versus, meaning insurance companies, versus organizations that both insure and provide health care. And I'm just wondering if you can provide some insights into the accuracy of that.
The accuracy is that they're correct. And again, just like volume has sort of laid bare the weakness or the fallacy that value is what drives the health of the financial health of healthcare systems, right? COVID has also done the same thing in terms of laying bare sort of how much money these health insurance companies make. I will tell you, the health plan has been instrumental in our own financial health because, as patients we weren't doing elective operations, patients were choosing to stay away from their clinics for fear of contracting COVID. That was less money that they had to pay for episodes of care, right?
Well,
so that was money that was held
all the
by
premiums, right?
Absolutely, yeah. They didn't start charging, right?
Right.
What you saw with companies like Anthem and Cigna and the national players, right, who have tens of millions of covered lives, that equated into windfall profits. And so you probably heard, in the popular media back in August, because so many of these, to Grant's point, so many of these private provider groups were going out of business because they weren't seeing patients. You saw sort of a supplementation of money from these national payers to private groups to help keep them afloat as a way to bail them out, because the CARES money didn't do a whole lot for them. I mean, it really didn't. And it's very disappointing, not that we want to turn this into a legislative discussion, that we're not seeing another bucket of money come out of Congress, because after December and January, I mean, I don't know. I don't know what to sort of make of what the health economic landscape will look like for systems after into the new year. I really don't.
Yeah, and I think in the larger frame, even prior to COVID, the biggest issue being that, there are other countries that have insurers. They're not a national health service, for instance, like France and Germany, yet somehow the profits are different. The scope is very different, and why we struggle in that.
I think part of the reason is that there's actually competition that balances the Darwinism, the unchecked Darwinism. Here, there's not. The only thing that we have, unless you're over the age of 65 or you don't qualify for health insurance, right? So you have to meet particular income, right? If you fall below a particular income threshold, then you're either on Medicaid, and if you're over a particular age, then you can get Medicare. But if you're right there in between, it's either employer provided health insurance, or you're buying something on the marketplace, or you can't afford any of those things, or you can't afford that, right? So there's no good competition that helps to sort of balance that. In these countries that have a national health system, national health service, you're absolutely correct. There are private payers that are out there, but they're kept in check largely because they know that, okay, I don't want to pay for this health insurance. I can go and get health care for free, right, from the national system that's out there. And that helps to moderate prices and you know, puts the right checks and balances in that system.
Thank you.
Thank you so much for joining us this morning, Ben. This was really helpful to our students, our faculty, and it sounds like there is a lot of interest in this presentation, so I'm sure you'll get a lot of YouTube hits if you're interested in those.
Absolutely.
Great.
Thank you again for having me.
Yeah, thanks for joining us. So happy Thanksgiving, everyone. Stay safe, stay well. We really look forward to seeing you in the new year. I think our next scheduled presentation will be January 26th. So mark your 2 months from now, and we will keep our calendar updated with who is speaking. Thank you, everyone. Bye.